He has been in the faculty of PGI Chandigarh. He is current faculty and chapters, and he has one big book on toxicology to his credit. We learn a lot from him. He is the international connection of India as far as toxicology is concerned. So, those who have not been able to make it to this auditorium, they will be losers. Dr. Ashish Bhalla.
Thank you for the kind words. Now, one thing which I must request, sir. Yeah, I would request, sir, please stop me whenever you feel that I've exceeded my time. I love listening to my own voice, and I can continue going for hours together because this is such a vast topic. I have a therapeutic window. Below that, it is, it'll have no effect, but above that therapeutic window becomes a poison. So, I give an example of plain simple paracetamol. We take paracetamol day in and day out, prescribe it day in and day out. But when you take more than 10 grams, it becomes a poison and it kills you. And if you continue taking paracetamol every 2 hours, again, that is staggered dosing and you may end up having a poison. What we've seen classically is in patients with dengue, when they come and you are giving them paracetamol, dolo 650 milligrams every 6 hourly, sometimes the fever is very high, you say take it even 4 hourly. Dengue is a hepatotropic virus, it affects the liver. So you already have a compromised liver and you are using paracetamol on top of it. So we've seen people developing toxicity with paracetamol in patients who are having dengue. So you need to be a little bit careful. You need to take the whole patient into context whenever you are using a drug. So when to suspect? The first and the foremost thing is when you cannot explain what is going on in a patient. Unconscious young male or female, mass casualties, people coming with similar kind of symptoms, all of them having a similar kind of symptom. And if you are suspecting that there could be a foul play. I'll give you an example. We had a patient, a female patient who came to us, who had severe lead poisoning. And when we asked her what was she taking, she said she was taking moringa leaves. She had a tree in the house. She would take out the leaves, dry them, crush them, and eat them. And there was no way you can get lead toxicity or arsenic toxicity. She had arsenic poisoning. No way you can get arsenic in moringa leaves which you are drying and crushing and eating. Although there are some Ayurvedic preparations from where you can get arsenic poisoning, so that's not it. So when we just took that off, she started improving. We started giving her chelation. She started improving, and the only one suspect was her husband. And we discharged her in a proper condition when she had improved. But a week later, she came back with aluminum phosphide poisoning and she died. So this means something was going on, somewhere something was wrong, which we couldn't pick up in right time. Although we suspected. History is very important. And as I said, environmental history, occupational history, recreational exposure. These days, a lot of new drugs are available, party drugs, which are there in most of the metros, making way into the smaller towns also. So you need to think of that as well. Environmental history is very important. Again, whenever I ask my residents to tell me what does the patient do, their answer is the patient is a farmer. Fine, he's a farmer, but what he does actually. So if he owns the land, he'll just be sitting in his car or jeep and going around and making around, coming back and sitting at home. And if he's actually working in the fields, he might be exposed to toxins, he might be exposed to pesticides. And people who are actually farmers, having their own land, growing their own wheat or rice, still do not deal with pesticides because they hire someone else to spray pesticides. So these things are important in context of what is the occupation, what is the environment in which the patient is living. And then you have to examine and you have to detect a toxicrobe. This is lucky with Sir, both of them sitting here, we frame these guidelines, and I think if you can get hold of this paper, must read this paper, because it actually tells you how do we approach and what all we are supposed to do and what all we are not supposed to do. Dr. Rupta, Dr. Ray were kind enough to include me as one of the authors of this paper, and this is a very nice document which has come out. Now, as soon as the patient comes, the question asked is whether I should resuscitate the patient or should I assess the patient first. Both the things go hand in hand, resuscitation as well as assessment. Unlike BAC, which is what is practiced now, right? Or CAB, which is practiced now, cardiac compression followed by airway and breathing. For poisoning and for trauma, airway is the priority. These are two conditions, trauma and for poisoning. Airway remains the priority. You have to keep the airway patent. Whenever you think that the airway is threatened, you have to be prepared to secure the airway doing rapid sequence intubation. You may use short-acting paralytic agent. And before you give any drug to the patient in which you are suspecting toxicity, collect one blood and one urine sample, because that is going to be your gold mine. Once you've given sedative paralytic agents to a patient, and then you collect the urine sample, you are likely to get whatever you have given to the patient in the urine. So the first sample of urine is important. Keep the air flowing into the lung, keep the patient breathing. If the patient is breathing on its own, fine. If there is a problem with breathing, then you have to ventilate the patient, check for saturation, very important. Now, very many people are scared of, or in very many books it is written that you do a arterial blood gas. I'm not very much in favor. Very many consultants, very many residents who are there in the ER are not comfortable taking an arterial blood gas sample. So if you have a pulse oximeter and you do a VBG, you get nearly the same result. Right? You might get slightly elevated PCO2, fine, that is all right, acceptable. But you get good oxygen saturation, you get all the metabolic parameters. So it should not be ABG, it should be blood gases, venous or arterial, if you pair it with your pulse oximeter, you nearly get the same kind of information. Third is that you have to keep the blood flow. How you keep the blood flow? There are two very important components. You have to keep the tank full and you have to keep the pump working. Tank full means your IVC should not be collapsed. There should be adequate volume, fluid volume in the body, and your heart should be pumping. Most important thing is all the poison patients should be on continuous cardiac monitoring because they may have an arrhythmia, they may develop an pulse oximeter can give you slight amount of idea how is the pulse behaving, but if you can put the patients on a monitor, that's very, very important. A baseline ECG should be obtained. Non-invasive blood pressure is as good as invasive blood pressure. Intensivists may or may not agree, but in an emergency setting, non-invasive blood pressure reading is as good as an invasive blood pressure reading. Invasive, not required in emergency because you may require expertise, you may require more time. So non-invasive blood pressure is very good. CVP has to be kept appropriate. IVC collapsibility should be seen. IVC should not be more than 50% collapsible if you are doing an ultrasound. And normal saline, 0.9% normal saline is the best fluid for resuscitation initially. You can later on shift to anything else you want to, but in an emergency setting, normal saline will suffice. Whenever you have a patient who's hypotensive, is unresponsive to fluids, you think of vasopressors, and the pressor agent of choice is noradrenaline. When you want an inotrope, dopamine is not to be, dopamine can be used, dopamine is not to be used. Dopamine is out because it can cause arrhythmias, so dopamine is not to be used. Noradrenaline and dopamine can be used. Now take a detailed history. The family members may not know and the friends won't tell you. So that's the, you always have to take it with a pinch of salt, whatever is being told. Patient may not be in a condition to actually give you a history. If you can get hold of what the patient was taking or what was available at home as medication, use the smartphone. Ask them to take a picture of whatever is the scene at where the patient was found, and you may detect something. I'll give you an example. During the COVID times, I just went into one of the looms, and I found a blood drop on the toilet seat. Why should there be a blood drop on the toilet seat in a male toilet? And then I looked carefully, I wanted to throw the tissue, and I looked carefully, there was a syringe and a needle line. So that was, that rang a bell, that somebody has been using this to inject. And we did find the culprit. One of the residents who was injecting drugs in the toilet. Only that one drop of blood gave an idea that something is wrong. It can't be there on the toilet seat in a male toilet. So these are important things. These are things which you need to remember or you need to be observant about. What is the type of toxin? When was it taken? What is the interval between ingestion and developing a symptom? What is the interval between ingestion and reporting to the hospital? How did the patient come to the hospital? Very many times you ask a patient, कितने देर पहले लिया था? वो अभी लिया था। अभी। कहाँ रहते हो? देहरादून रहता हूँ। देहरादून कितनी दूर है? यहाँ से 40 किलोमीटर। कितनी देर लगी होगी यहाँ आने के लिए? आधा घंटा लगा होगा। अभी लिया तो नहीं हो सकता। So patient has to be taken out from where he has taken the poison. put it in a car or a vehicle and brought to a hospital, that will take time. If the patient is on first, second, third floor, they need to be brought down. So all these things need to be taken into account whenever you are talking or taking the history of the toxin ingestion. And as I said, evidence of the scene or evidence rather than the scene, very, very important. We have strong recommendation that basic investigation, initial investigation should always be done, including an ECG, including capillary blood glucose, and including a blood gas analysis, all the patients, and a very strong strong recommendation that at the outset, basic IV fluids oxygen should be given to all the poison patients, a continuous ECG monitoring should be done, and then a toxidromic approach should be applied. Now, what is a toxidrome? Toxidrome is a constellation of signs and symptoms which tells you that this particular poison is likely that the patient has consumed. Now, you have to perform a head-to-toe examination, but remember, stabilization of airway, breathing and circulation at any given time when you are performing the examination also takes the priority. So once you start examining the patient, you feel that the patient's breathing is becoming difficult or blood pressure is going down or there is an arrhythmia which is coming up, you stop and you start resuscitation again because stabilization is the important thing. Scene safety is number one. A poison patient can be agitated, may be violent, may be intoxicated. So you need to save your skin first. So always take the help of people who can restrain this patient. Pharmacological restraint is important, but physical restraint is also needed at times when the patient is violent. AVPU scale is the simplest scale. You can alert, verbal, painful or unresponsive. Very simple thing, you can record and you can reassess the patient again. Look for signs of injury because that's very important. Any poison patient may have fallen down, would have injured his head or neck and can put his life at risk. Staining of clothes, vomitus, blood, urine and stool, very, very important. Because what happens is when a person becomes unconscious, he is vomiting. That vomitus comes onto the patient's clothes on the chest or abdomen. And sometimes in a female patient, it can there be even the hair and the scalp. So when you talk about decontamination, these are the things which you need to take care of. Always look at the skin, the lips, the nails, because they are important. Very many people, they snort drugs, and you may find some powder at the end. And if you take a sample from there, you may get an idea at a later date what is happening. Look for tattoos, needle marks, they are important. Most of them are very, this might be a bias, or maybe I am an old timer. If I see a tattoo on anybody's skin, any young person, male or a female, my first thought goes, one, drug addict, two, what about the sexual preferences of that patient? Two things I always be asking. Maybe I'm an old timer, but anyone, if I see a tattoo on anyone, these are the things which start coming in my mind that something wrong somewhere. So head-to-toe examination, I am not going into the details, but you have to look at everything from skins to nails to muscle, vitals, cyanosis, everything has to be looked at. And the idea is to identify a toxidrome. These are classic toxidromes which are there. We all know about the cholinergic toxidrome. There is meiosis, tachycardia, weakness, tremors, fasciculation. The classic example is opiate poisoning. And then you have, diarrhea, diaphoresis, urination, bradycardia, bronchospasm. And bronchial secretions, these are the things, or the three killer bees are bronchospasm, bronchial secretions, and bradycardia, which will kill the patient. Datura poisoning is very important or very easy to remember. Why? Because whatever you see when you're treating OP poisoning is atropine overdose. And atropine overdose is nothing but datura poisoning. Right? So a patient comes with OP poisoning, you start treating him with atropine and you give him another poisoning, which is hypertonic, that is atropine. Because the action of atropine is to dry the skin, give you tachycardia, right? And make you feel flushed. That's what is desired in OP poisoning. So if patient comes with one poisoning, give him another one to take care of the first poison. Now these are classic things. Sedative hypnotics are described that person may be sedated, may have normal pupil, may have decreased respiration. The common example there is your opium, your benzodiazepine, these are the things which can cause sedative hypnotic effect. And very important again is serotonin syndrome, where the patient may have altered mental status, tachycardia, hypertension, and hyperreflexia. Now, the classic thing about serotonin syndrome is that your upper limbs may not show you hyperreflexia or clonus, but your lower limbs would definitely show you hyperreflexia and clonus. So, any patient in which there is a recreational drug poisoning, you always look for ankylclonus, and if you find ankylclonus, then this patient probably is having a serotonin syndrome. Three things which I wanted to talk about, which is not written in any of the textbooks. One is a phosphite toxicrome or a phosphine toxicrome, we can call that, or a metal phosphite toxicrome, where there may be tachycardia, hypertension, tachypnea, but the patient is usually alert. This happens in aluminum phosphide, zinc phosphide poisoning. Corrosives, not written because in Western countries, you hardly see corrosive, we see that more common. That is pain in the throat, stridor, drooling, and if you examine the oral cavity, you may find ulcers. Patient is again alert. And third is acute liver failure mimics, and the acute liver failure mimics present with jaundice, bleeding, and the sensorium may be altered. And the classic example of that is yellow phosphorus. I don't know whether you've seen yellow phosphorus poisoning. We've encountered a couple of cases. In South, it is very, very common. But the jaundice, bleeding, and altered sensorium doesn't happen on day one. It is a delayed manifestation. So acutely, patient may not have many of these symptoms, but later on, another cause of ALS mimic is paracetamol, because it again presents with similar kind of jaundice, altered sensorium. Bleeding may or may not be present there. This is the most important thing: decontamination. Whenever you are decontaminating, you have to weigh the balance between potential risk and foreseeable benefits. The triangle is very, very important. Whether the patient has consumed any toxin which can potentially threaten his life, and the intervention should be beneficial and may not cause more harm. Now, what is very important? Why this picture is here? This is a picture of how you manage a patient with nerve agent exposure. Now, why nerve agents are important? In context of the recent war, Iran is supposed to have chemical weapons. So it's very, very important. So what is important? What is the first step which is written is spot decontamination, remove the clothes. If you have been exposed just by simple act of removing the clothes, you can decrease the exposure significantly. Second is you have an early toxicrome recognition. You look at what is happening to the patient, try to. Third thing, very important, is antidote. Now, I that you have a OP poison patient who comes to you in the emergency, he's vomiting, or an aluminum phosphide poison patient who's come to you in the emergency, who's vomiting. What is your priority? Decontamination or antidote? Resuscitation or antidote? My first priority is resuscitation. I would prefer an alive patient who's contaminated, who's breathing, rather than a dead patient who's decontaminated. So my preference is intubate, resuscitate, give antidote first in case you recognize the toxicroom and there is an available antidote. The example for that is if you had opioid toxicroom, there is significant respiratory distress. Before you even consider intubating this patient, Narcan can be given. And there is recommendation now that in a recognized or suspected opioid toxicroom, before you consider intubating a patient because of respiratory distress, you give naloxone. And many times you can avoid putting in a tube in them. Similarly, in a patient with OP poison, who's having bronchoria, who's having bronchospasm, you think you want to intubate this patient, first give atropine. Because with giving atropine aggressively may prevent intubation in not all, some of the patients. You can still prevent, intubation in many patients if you are giving aggressive atropinization earlier. Skin decontamination, very important. Just plain simple water is more than enough, but then there are specific, agents available which can take care of some of these agents, chemical agents. This is a beautiful chapter, a review article. You can go through this. It lists all the disinfectants commercially available which can be used to decontaminate or remove the toxin from the skin. A question again asked is, if there is a mass casualty scenario, mass exposure, what do you do then in that situation? Simple thing is, water these people down from head to toe. कहाँ से इतना पानी लाओ? Think out of the box. पुलिस के पास होती है, उनके पास वाटर कैनन होती है, और वो वाटर कैनन किसके लिए यूज करते हैं? प्रोटेस्टर्स को भगाने के लिए. Ask for that. If there is a mass casualty situation, mass exposure, ask them to spray people with that water cannon. It will take care of most of the toxins which have been there from head to toe. But in case you need a specific decontamination, then you set up these decontamination units, and then you can decontaminate with water these people. Traditional approaches were Cenophobe apicac, which we read, it induces vomiting, gastric lavage, forced removal, clear the gut, four bowel, irrigation, universal antidote. Somebody from forensic care, when we were reading, it was a big thing. Burnt toast, tannic acid, useless. Don't waste your time on things like that, right? Don't do it. It's no longer recommended. Activated charcoal, the evidence for activated charcoal came way back in 1831 when they said that if you give the animal strychnine along with charcoal, it prevents the strychnine toxicity. That was the first thing which it was being used for. But remember, activated charcoal is not burnt toast. Activated charcoal is specific, right? It's available. कहाँ से खरीदेंगे अगर खरीदना होगा? Amazon में मिलता है. You can buy activated charcoal as much as you want. People use it as detox drinks. आजकल फैशन है. एक्टिवेटेड चारकोल का सैशे काटो, पानी में डालो, घोलो और पी लो. Detox. In one of these 7-star hotels I went, there was a detox drink kept there. It was nothing but charcoal and water. You could drink that. Remember, charcoal doesn't bind to pesticide, doesn't bind to corrosive, doesn't bind to heavy metals, doesn't bind to petroleum products. So it's useless. Don't use it. And there is efficacy of activated charcoal against some of the pharmaceutical agents. So activated charcoal, this is a position statement which was issued by American Academy of Clinical Toxicology way back in 1997. That with the first couple of hours in selective it is of some use. Gastric lavage. Now this is, do I still have time? Still 5 minutes. Okay. I'll just talk about gastric lavage because this is water gets out of, or any liquid gets out of your tummy within 1.5 hours. If a patient has come to you after 1.5 hours, after consuming pesticides, what will you get? Nothing. So why are you doing gastric lavage? There is a study by Dr. J.V. Peters. If a patient has come to them within first hour of consuming pesticide and they put in a nasogastric tube and took out the contents, less than 10% of whatever has been taken was removed. So it's useless. Don't do it. If it is within 1 hour, you may still want to try. Beyond 1 hour, no point. Solids, yes, they stay in your tummy for a longer time. Pharmaceutical drug plant products, they will stay in your tummy. If you have sustained release preparations which have been ingested, they will stay for a little longer. So it may be used in ingested solid poison, preparation forming bezoars, and poisons which can cause pyloric spasm. Right? So there it might be of some use. And how do you use it? There are no randomized studies available, but then it can cause complications. So the ideal time of performing it is within first 1.5 hours to 2 hours for liquid poison, and up to 3 to 4 hours if there is a solid poison which has been ingested. Although we have not been doing this, but this is one study which we performed that nasogastric tube is safe. Not the conventional forensic medicine stomach or gastric lavage tube. Don't use that. It's very complicated. It causes more harm than good. If you want to take out this solid poison, do an endoscopy. It is easier. You can visualize what is there and you can take it out, right? If there are solid things about it. What about ghee, milk, potassium permanganate, liquid paraffin? There are risks of aspiration, and if you read the older books, there might be egg white, there might be milk. Useless. Don't waste your time on these things. Whole bowel irrigation. If there is no intestinal obstruction, there is no perforation, there is no IBS, no GI bleed, and if there is no persistent vomiting, then you can use peg-leg, right? And again, for plant poisons and pharmaceutical agents, this is something which can be used. There is only one use of Fuller's earth. Fuller's earth is मुल्तानी मिट्टी. अरे घर पे मिल जाएगी. लेडीज यूज करती है, मुंह पे लगाती है, मिल जाएगी. अगर कहीं और नहीं मिल रही, घर से उठा के जाए. But that the only condition where it has been found to be useful is paraquat. But paraquat has corrosive properties. If there is a hematemesis after paraquat ingestion, if you are suspecting that there could be a perforation esophagus or gastric, don't use Fuller's. But it can be used. If you don't have Fuller's, you can use activated charcoal upfront within first couple of hours. Not beyond that. So this is again a paper, you can go through it. I will not, again, the patient has taken a substance which is potentially toxic, has come to you in a time, is the ingestion massive? Is the patient there early? then you perform a gastric lavage. Otherwise, there is no need to do gastric lavage. Again, the position statement, we come out with recommendation which are against the use of gastric lavage, because it may cause more harm than good. Planned investigations in a female, don't forget but then they have their own issues, can be performed, but you should always remember what are the limitations. Fluid here, they are again important, but they can be used for detecting chronic missing. ECG is very important because it can tell you whether it is a narrow QRS, wide QRS. It is only atropine, narcan, and soda bicarb. Soda bicarb for TCA, for tricyclic antidepressant. There you may use soda bicarb early because if you have a QTC prolongation, there is a role of soda bicarb giving. List all the common poisons, get the antidote, stockpile, help others. It's important. What is your problem? You know which antidotes you would like to stockpile. Don't stockpile things which you don't need. क्योंकि expiry होती है, वो फिर पैसा waste हो जाएगा, उसका कोई फायदा नहीं. These are two things which are important coming up. One is lipid emulsion therapy, local anesthetic poisoning, and again autotoxicity, and calcium channel blocker and beta blocker. Lipid emulsions 20% are easily available in most of the hospitals where surgical intervention on GI are performed because there is a part of the parenteral nutrition. So if you have a severe calcium or beta blocker toxicity, calcium channel blocker, beta blocker toxicity, you can use that. For alcohol, methanol, you can use ethanol. Remember, जो ethanol available है ठेके पे, उसको IV नहीं दे सकते. That can be given orally, but it needs to be diluted and given orally. Problem with ethanol given orally for methanol poisoning is it will make people drunk, and to control drunken behavior has become even more difficult, right? So the drug of choice is fomepizole. Fomepizole is made in India, not available in India because it is exported. बाहर मिलती है, यहाँ नहीं. I have access to some fomepizole. I have around 100 vials available with me because we are doing a project on methanol. So under that it's available. So in case you need, either you can send the patient to me, we'll give you fomepizole, we'll give the patient fomepizole, or you can contact, we might be able to spare some if you need some. When do I admit a patient? When you have a respiratory failure, or there are patient is intubated, acute heart failure, hypertension, myocarditis, severe acidosis, coma, need for dialysis, body factors, snake bites. They should all be in an ICU because these are the patients which will require intensive care. I'll leave the slide here, hemodialysis or hemoperfusion. There are select indications for performing hemodialysis and hemoperfusion. Important, you have a dialysis unit, I've just seen it there. So you can do a dialysis even if you don't have hemoperfusion early in the course for toxic alcohol, for lithium, for potassium, and these are the conditions for paraquat. Paraquat, if you do not have hemoperfusion, even doing hemodialysis early may benefit the patient. May. I'm not saying it will, it may benefit. But in case you don't have hemoperfusion, don't deny a patient hemodialysis. And I think stop here. The biggest challenge, this is the last slide, the biggest challenge is withhold unnecessary treatment. Withhold intervention which may be dangerous. And for that you need to know actually what are the interventions which may be useful. Intervention without evidence doesn't work. Everything new like lipid emulsion will not work for every poisoning. We've used it For OP, we've used it for aluminum phosphide. We found some good results, some bad results at times. So everything new may or may not work. Intolerance or ignorance is not a bliss in toxicology. And wherever you have a challenging case, you can always think of us and you can always call. So I'll leave you with this is the textbook we've come out with. And in case you have any questions, I had my email somewhere, it's not visible. So you may have my number, call me anytime, more than happy to. Thank you.
Any questions for Dr. Bhalla? Please feel free.
Whatever you learned in your MBBS, you have to unlearn.
कहते हैं प्यासे को कुएं के पास जाना पड़ता है, कुआं प्यासे के पास नहीं आता। यहाँ आज उल्टा हो गया।
पर सर हमारे ग्रेजुएशन में हम यूनिवर्सल एंटीडोट से ही पास हुए थोड़े से सर
पेशेंट ठीक नहीं होगा, एग्जाम में पास हो जाओ।
पास होने के लिए जरूरी है। व्हाट इज
universal antidote was at that time was a black card, then it can add and you add
फोरेंसिक पास करने के लिए वो आना ही चाहिए।
The forensic medicine trade has also changed. Forensic medicine has also changed of late. मैं कह रहा था कि आज कुआं प्यासे के पास आते हैं। You all know that we are trying to create an antidote bank here, and we have been hunting for omeprazole for last 3 months. We have not got any response even from Cadila, who are manufacturers in India. Dr. Bhalla has offered to give us as many as he can spare, at least 5. We will send you an official request, sir. So, कभी कुआं भी प्यासे के पास चला। It was an eye-opening presentation, talk, and I know Dr. Bhalla for now more than 25 years. I have been learning from him. So, our next lecture is by a person you will never forget after hearing him, Dr. Dilip Punde. Dr. Dilip Punde is a dedicated clinician. He works, despite he has all the resources, he can enjoy his life. His son is a cardiologist. Is that right, sir? But he lives in a remote village, in remote corner of Maharashtra. What access to current luxuries he has, I do not know, but I presume sparse. He works round the clock. He is available to his patients 24/7 at 2 a.m. to any time during the day. He will describe how he works, but he is master of the subject, and the subject is snake bite. Nobody in the country has ever treated patients with so much dedication as Dr. Dilip Punde does. And nobody that I know can talk about his topic with so much eloquence as Dr. Dilip Punde does. You will be mesmerized when you listen to him. He was invited by the President of India as one of the top 11 doctors of the country to witness 26th January parade this year, and I have heard so much about him during my last 1 decade, but heard him only recently, about 6 months back at Kolhapur, and I was literally taken aback with his ability to move pointed out, hold them, in absolute silence, and only thing that audience can do is focus on what he is talking. Dr. Dilip Kunde, snake bite. Can you give them a big applause?
First of all, I am grateful to Dr. Rumta sir, as he has appreciated my root level work. I am really grateful to him. I am here amongst the all legions of medicine. This is something out of nothing. I am working at a remote rural part of Maharashtra. I am the first MD to enter the rural pocket. I passed in 87 and since then I am working. So I really salute to the soil of Devbhoomi. 2 years back I had been to Char Dham. This is my hospital. I am at the corner of Maharashtra, so 30 kilometers is Telangana and 30 kilometers is Karnataka. Working since last 39 years, more than ICU to 20 acres. It's a one-man institute. Almost managed 10,000 bio cases with the record. Records are available with me. In 1988, our mortality was around 25%. Due to snake bite. In last 2 years, in our area, we have achieved 0%. My center is around ICMR center, and I am one of the contributors of NAPSA. Dr. Bhalla sir was in that list also. We lose 81,000 to 138, but actually this could be a tip of iceberg. India loses more than that. Snakes are worshipped in Indian culture like anything. You can see the stunts on social media. This is India. You will be seen in every village of India. Not a single village will not be having this dance. So snakes are rooted in Indian culture. Why snake bite is so common? That is how poverty leading to poor conditions. Farming is the main occupation.
Hence, the risk is 24 into 7 into 365. So this is the real scenario at root level. This is, you can see the living situation, barefoot walking, then snakes has to be there. Actual real scenario. 3 to 4 million snake bites every year in India. Some studies show that it is 60,000. Few show more than that, but high mortality in rural population. This could be the tip of iceberg. There are almost 2,000 snake species. 315% are venomous. India has 252. Out of that, 52 are venomous. But we are dealing with the big four: Elapidae cobra, correct king cobra, then Viperinae, pit viper, and sea snakes. But we are facing big four. You can see the cobra, naja. Second is a crate, ungaris. Is a glistening black snake, very, very dangerous. Russell viper and saw scale. For legality, I will put Russell viper first, then crate second, cobra third, and last is a saw scale. Monoclinic in Maharashtra, but they are seen in West Bengal. These are the pit vipers. I don't have experience operating pit viper and sea snakes. One should be aware of non-venomous bites. In our area, at least 30% patients they bring the kill snake. Because of awareness, they come with the kill snake. All these are the non-venomous bite. Why? Because in India, many doctors they give ASV to the non-venomous bite. I have seen lot of medical officers they pour ASV to the non-venomous bite and they won't give ASV to the venomous bite. Lower slide, left one is a crane, is a 10 times dangerous than cobra. Right one is a common wolf. That is highly venomous and this is a non-venomous and mistake. Snake venom is a lytic cocktail. It has a neurotoxin, cholinesterase, hemolysins, fibrolysins, you can see all. One thing is that snake venom has a regional and seasonal variation. Snakes of Tamil Nadu are more dangerous than Maharashtra. West Bengal is something different than Maharashtra. It is a three-finger toxin. Now the real clinical approach at midnight, some patient comes with unknown bite or some bite. Lot of people they gather. Take a history, time and place of bite. Dr. Bhalla was insisting on the history. Sir, if patient comes in the early morning, 5 a.m., 4 a.m. with abdominal pain, think of crate. If patient comes at 6 to 7 a.m., think of cobra. That is a natural habitat. And vipers you can see day and night hours. If my staff says a snake bite hai for 6 to 7 a.m., my thought goes, is it cobra? Second is activity. Was he sleeping? Likely to be great. Then examination, species identification, whether snake is seen by patient, snake is brought by patient, whether he has brought killed snake, and last is whether he has brought a photograph, and last is a systemic exam or syndromic approach. This is not a rule of thumb, but this will give clue. Two marks with or without edema. Could be a venomous bite. 2 fang marks with other U-shaped marks could be venomous with edema. Only U-shaped mark is likely to be non-venomous. Single mark, single abrasion, 2 abrasions, no marks occurred by. This is not a rule of thumb, but this can definitely support the diagnosis. This is non-venomous, multiple. but one should not believe on that. Now this is by WHO. Now we are many in India. This is followed as per the standard treatment guidelines. If a local envenoming patient comes with a bite, he has seen the snake, but he has not brought the snake. Local envenoming with a bleeding, clotting disturbances, this is a viper. All vipers. If local envenoming, swelling with a bleeding, clotting, shock, ptosis, this is a Russell viper. If a local envenoming with a fast paralysis is a cobra or king cobra. I don't have experience of treating king cobra. If patient comes with a paralysis, very minimal or no local signs, abdominal pain, sleeping on the ground, early in the morning, is a and syndrome 5, paralysis with dark brown urine, AKI, that is the Russell viper of South India. I have taken the photographs with the due consent of the patient. Neurotoxic bites, I will not go into the details, but the venom blocks the neuromuscular junction. That is presynaptic in crate and post in cobra bite. Always remember 5 Ds: dyspnea, dysphonia, dysarthria, diplopia, dysphagia. And 2 Ps, ptosis and paralysis. 5 Ds and 2 Ps is a neurotoxic bite, descending paralysis. Post, you can see the ptosis immediately after cobra bite. This was a very old slide. Initial days we used to save a lot of money on Ambuban. She was taking roti. A rat was there, behind the rat cobra was there, and she was bitten by cobra. Now these cases, yes, in last year I have treated. Upper one, she was sleeping. Cobra, she was bitten by cobra on the cot. Second, she pulled the cobra by left hand, and relatives told that she is dead. We did CPR. They were not ready to accept the treatment, but we did MSC and she was saved. All these are the cobra bite cases with respiratory paralysis. That is a wonderful slide. This girl, 6, 7, 11 months old. She had a cobra bite in front of doctor, sir. She was in Anganwadi. Child was brought for immunization, and Anganwadi, whether Anganwadi concept is here or not, I don't know. Doctor was sitting there, and cobra came from the ground, and child was bitten by the cobra. I am not a pediatrician, but it was a big puzzle for me. We give full dose because child and adults they require full dose. You can see the cobra, child, and we could save the child. So very beautiful to treat snake bite cases in rural pocket. They will not reach more than 25 kilometers. They will not reach. So medicine is a science. Medicine is a thrill. It's energy, enthusiasm, frustration, depression. But I consider mixture. It is a mixture of all. It's a festival of saving lives. 11 months cobra bite child we could save. This girl was brought at 1:20 a.m. Now I was upstairs, inside upstairs, almost gasping. See the huge cobra. She was irritated. I visited her house. See the house pattern. House is surrounded by ant hills, and there was a big cobra. CPR, we did the CPR. Now the second important is the crate bite, presynaptic. History is very important. Abdominal pain, descending pain. occurred by patient is not at all knowing, and there is a locked-in syndrome. It's a 10 times dangerous than the cobra. Defined as a quadriplegia and anarchia with the present preserved consciousness. Patient is paralyzed. We think that patient is not knowing. Patient knows everything. Usually occurs in every bite. That is correct. Early morning in the OPD, patient opening his own eyes. That could be a great bite. Typical neuroparalytic syndrome. Great is called as a Surya Kanda. Patient is bitten at midnight. He woke up with abdominal pain. He goes to GP. Some diclo is given. He is a neuroparalyzed. Sun comes up. Patient dies. Hence, great is called as a Surya Kanda. So this is a consumption of a viper bite. Pathophysiology. This is a coagulation cascade failure. Phospholipase A2 is a main culprit. There is a destruction of capillary intravascular endothelium. This is, you can see the Russell viper bite. Rapid progressive edema, vomiting, shock, bleeding gums. Few cases they present with ptosis. You can see the cobra bite came within 1 hour. He had a bite on digit. He is bleeding orally. Soft scale in aurea is somewhat less dangerous, but definitely not the lethality in changing. First aid and proper transport is very, very important. Specific management, then complications and local site. This is approved by Government of India. You will have to apply tourniquet controversy. People they apply multiple tourniquets, and this is transport way. You can see. The patient should be in between two. If a cobra bite patient is behind, he will be neuroparalyzed and he will meet with an accident. Okay. So the complications, then management of local site. Sorry for the interruption. We educate the people. We have done the mass education of 5 lakh people regarding the identification of the snakes, what primary aid should be. We teach them CPR, and a lot of patients are coming with CPR, sir. We are saving the lives. This is now this directive is published by Government of India. Do's. Take away the patient. Then don't just prevent fright and flight. Patient should not run. Reassure, right. Remember the word right. Reassure, immobilize, go to hospital is the primary treatment. And in don'ts, you can see. Do not pour any herbal medicine. Do not cut the bark. Do not take the patient to the temple. There are do's and don'ts. He has first one, upper one. Multiple tourniquets that is causing arterial ischemia. These two fingers they called the carpenter and finger was out. Lower one. That lady had a cobra bite and that old man with the mouth suction. Mouth suction is possible only in Hollywood, not in reality. It should not be done if there is a neurotoxicity. Tourniquet should not be released immediately before administration of ASP. If patient has come with a multiple tourniquet, if you release the tourniquet and gush of venom goes in, and patient had arrest, and the relative will catch your neck. Scenario is very different in rural situation. Very few things are possible at group level. We don't have a very high-fi labs. CBC, 20-minute whole blood clotting. Now we are doing LFT, coagulation profile. Bedside test. Take a 2 cc of venous blood in a new test tube. Keep it for 20 minutes. After 20 minutes, just reverse it. If blood is not clotted, that indicates consumption coagulopathy and indicates this is a hypertrophy. But it should be repeated. Otherwise, in many hypertrophy, that test is negative. What are the indications of ASV? Rapid progressive swelling, swelling more than one joint, swelling after bites, local bleeding, necrosis, development of regional lymph node. If patient has a lymph node, 100% this is a venomous. Then neuroparalysis, cardiovascular abnormalities, arrhythmias, bleeding, diathesis, abdominal pain, all these are the indications. Incoagulable blood, thrombocytopenia, change in PT, APTT, FDP not possible at rural pocket. No absolute contraindication for ASV, only by IV route. Keep adrenaline ready. If you don't have adrenaline, don't treat snake bite patient. My policy is I prescribe ASV kit, I take in my pocket and then we pour ASV. Many times atropine is wrongly, atropine is taken considered as adrenaline and adrenaline wo dikhta nahi. Now we are using, studies are published, 0.25 cc subcute adrenaline before ASV if not contraindicated, and this has drastically reduced the reactions. Sir, this is a protocol now approved by STG. If cobra bite, pour 10 vials within first hours. If no improvement, pour another 10 vials, this is 20 vials. Great, 10 vials. If no improvement, 20, further 10. So cobra crate 20 vials. Viper 10 vials in first hour. Patient is bleeding. Now we are giving 20 vials stack. Repeat 20-minute whole blood clotting test. Total 100. Sostel white 4 to 6 vials. But if you are thinking that this is a respiratoxic and not able to identify, or 10 vials. Any referral of venomous bite should not be without 10 vials of ASV. Venom detection kit, they are coming in market now, but yet too, you must have read about that. They will only identify venomous or non-venomous, but they will not identify. So the why treating snake bite is difficult is because of reaction. Many doctors they don't touch snake bite because of fear of reaction. So if there is a reaction, you adrenaline boldly. They are much have fear regarding adrenaline, then chlorothalonil. Patient may have pyrogenic reactions. Policies are if patient comes with venomous bite, put a intracap, play drip, another drip. Do prophylactic adrenaline or ASV. If reaction comes, stop that drip, treat the reaction, start with same drip again. For a neuroparalysis, atropine plus loading new stigmine, a cobra bite should open eyes within 10 minutes. 5 to 6 doses, they are generally sufficient. But crates are not, they are non-responders. But initially 3 doses are tried. If there is no response, leave it. We have initial days treated ambulant patients for 42 hours. Oxygenation, care of tube. Fixed and dilated tubing in neurotoxic snake bite is a sign of envenoming and not the sign of brain death. I have seen neurophysicians, they declare brain death, patient woke up after 2 days. This lady came with a great bite, you can see the fixed dilated pupil. For 3 days, she was on anti-comatose. On 6th day, she became alright. Very at root level. restricted resources. This is a wonderful story. Sir, this man was referred to me as a case of infection. He had a chest pain. ECG was normal. We diagnosed to be a snake bite. Relatives not ready to accept the diagnosis. He was put on venti. I told that this is a snake bite. They went back, brought a cobra from his room. I told that this is not bitten by this snake. They again went back. They bought the crate. On one side, crate on another side, family inside. This is the real India. Reality is different than reality show. After the crate one. See, we can absolutely after she was not aware. June, in the month of June mainly. So this is a crate bite. Now you can see the dorsal. If a patient of crate bite suddenly dies, think of arrhythmia. It was because of hypokalemia. We could treat it. Dorsal point is at this junction she had severe hypokalemia. There were no other QT prolongation drugs. It was the cause was only hypokalemia. So these are four types of crate. Rheumatism, common crate, now vulgaris, cinder crate. Sir might have experiences in the crate. This is a very, very dangerous. See the mouth oral. Now this is a Romulus Whittaker crate. Romulus Whittaker has an extensive study. But cinder crate is more dangerous than common crate. We are dealing with the common crate. Calcium gluconate is now a recent trial. It is definitely, it is a presynaptic neurotransmitter, is a calcium, and definitely it helps in current white 10 ml 6 hours until the reversal of neuroparalysis. It will fasten the recovery. Treat the complication: hypovolemia, anaphylaxis, cardiogenic, septic, and ASV as per the cause. Sir, this patient had a muscle member bite on a digit. Both of them have. Before bringing medicine, both patients had a cardiac arrest. So bites on fingers and toes are very, very, very dangerous. They become intravascular bite. You can see CPR. Don't hesitate to don't be. I will say don't be to declare the death. With CPR, you can show many lives. This is a wonderful case, sir. 55-year male came with the unknown snake bite, but it was a vasculotoxic bite. We infused ASV, had a reaction, treated with adrenaline, developed infection, developed fibrillation, then there was a coagulopathy, defibrillation was done, lastly thrombolysis was done, lastly patient was sent to cath lab. This is a double trouble. Lady had a non-venomous bite. You can see the cat snake. Suddenly she went into shock. It was the inferior wall MI. So every bite patient should be observed at least for 24 hours. She was hospitalized with streptokinase. Cardiac manifestations are common. Fibrinogen deficiency, consumption coagulopathy. ASV is a mainstay. FFP is indicated only in case of severe bleeding. 15 ml per kg, now maximum 30 ml. Cryo 1 bag. Heparin is not recommended. If no active bleeding, wait. Lower platelet or platelet less than 30,000, RDP or SDP. Repeat coagulation profile after 12 hours. They are repeated 12 hourly. Generally within 48 hours to 60 hours coagulopathy is corrected. But coagulopathy in pit viper, there might be pit viper in Uttarakhand. There is no role of ASV. Coagulopathy remains for 10 to 15 days. Again, there is a chance of trolley, complications, anaphylaxis. This is a ATM proliferative nephritis, interstitial nephritis. This is a histopath of a kidney. Treatment is catheterization, early dialysis. FFT we have tried, but we couldn't get a good results. Treat hyperkalemia with calcium gluconate dextrose. Hypokalemia, you know. So this is a local edema. C for compartment syndrome. Fasciatomy should be avoided many times, otherwise patient bleed like anything. That is a routine treatment, maxillary proper antibiotic. So worst case, worst complication of Russell hyperbite is capillary, 85 to 90% mortality. There is a dysfunction of vascular endothelium, yet no one could identify the antigen for capillary leak syndrome. There is a sudden drop in pressure, chemosis, hemoconcentration, patient has a multi-organ failure. It is also called as Clarkson's disease. You can see this case. This patient was saved. Mainstay was ASV, inotropic support. He had a hematuria, pleural effusion, everything. These are the complications, necrosis, gangrene. We are routinely facing all these things. This lady was saved again with CPR, cobra bite, extensive necrosis. They were posted for skin grafting. So this is cobra bite. Hypertension after crack bite, we have observed. Hypopituitarism, hypothyroidism, neuropathy is not common, persistence of swelling in Russell viper bite. This girl had viper bite at the age of 13, was menstruating. After 6-7 years, she got married. She was evaluated for infertility. We published this empty Sella syndrome. This is a pan-hypopituitarism. So this is a good case. Man was bitten by wild beast. While running, he had a viper bite. And when he was brought to, he was in shock. We gave adrenaline and ASV. He had a massive reaction. So this is a triple trouble. Honeybee, Russell viper bite, and shock. In spite of that, he came out. This patient had stroke. He died. Sir, I have treated at least 50 to 60 snake bite with ANC. Upper one is great bite, 7 months followed till delivery. Second one is again cobra bite. This last one child. That lady was having 9 months amenorrhea. She went for defecation, had a cobra bite. She was put on ambu bag. Next day delivered normal child. After a few months, she came to me and asked to name this child. He is Nagesh. Lower one is a Russell viper bite. Now, this is a good case. Parents declared that he is dead. Ear in a great bite. I went into that trolley. He was gasping. We put this patient 42 hours on ambu bag lockdown. On Diwali day, we could take 8 cases to see. I told him, up to Namaskar, okay, we have done a massive mass awareness in his area. Awareness is most important. You can see the cobra bite at vertex. While doors are very small, while entering the house, there was cobra. Second, he grabbed viper in wooden bundle. Third, this child took a snake and put into oral cavity. Great, and you can see the intestine. Many times, if there is a great and king cobra, they eat another snake. So we warn every patient of great bite that there is a likely chance of another snake. He came in fluid situation. he came with the 3 snakes. I was, whole night I was downstairs, ultimately it was not even a spike. So lot of research is going on, but research should go to lab to land. Lot of research remains in metro. So the education is a process of socialization. Education means tiers of the last man of the society. What are the future directions? Now infrared thermography, measurement of enzymatic activity, molecular biology, lot of work is going on. AI is doing lot. Venom detection kits. Use of nanotechnology, more purified human monoclonal antibodies, toxin-specific TPPs, then specific channel blockers, but nothing is in the pipeline. Now, somebody was talking about the universal antidote. Sir, this study may go in that direction. SVHM, that is metalloprotease, that is batimestat and marinastat. Second is PLA2 inhibitors, that is persiflage. If these two combine together, there can be a universal antidote for snake bite all over the globe. This will be a game changer. Postmortem findings, one case is in Calcutta, one is in Kerala. Nothing more is found in neurotoxic bite, but hemorrhages are seen in respiratoxic bite. But only reports are comprehensive, clinical, circumstantial, postmortem finding, toxinological approach, histopath, etc. In legal views, there was one case reported last month in Maharashtra, also homicide. So there is one policy, every patient should be done MLC, for that is helpful for compensation also. Now NAPSID, sir was there, National Action Plan for the snake bite envenoming, aim is to reduce 50% mortality by 2030. So this is the chart published by Government of Health Ministry. Always remember word PONDS, P-O-N-D-S, P for pain, O for oozing, N for nodes, D for discoloration, and S for swelling. PONDS, P-O-N-D-S. If you can see the PONDS, it is a venomous bite. P for pain, O for oozing, N for nodes, D for discoloration, S for swelling. So the basic is health education, mass awareness. We have educated 5 lakh people. Learning more is the ultimate antidote. Learning, learning, learning. This was an international meet. Sir, we are conducting a lot of mass programs for CPR. He is my son, cardiologist. Lot many patients of cobra bite, if they are brought with CPR, they are saved. Sir, we are distributing free gumboots. Our policy is we give gumboot to every patient. Lot of NGOs they come out. We felicitated. Our mission is save the savior, teach one each one, and mission zero mortality. We have distributed gumboot. Sir, he was ex-MP. He survived for 103 years. He was bitten by crate. Until his last breath, he conducted lot of mass awareness programs. Mr. Dholke. I will describe only your sleeping habits. Snake bite is not common in Muslims. It is common in Hindus. Why? Poorest and poorest Muslims, they use charpai. The Hindus, they sleep a single room. So the sleeping habit should be, if you are sleeping in the single room, at least keep 1 feet distance from all sides. Snake is a reptile, snake will go away. But what happens, we keep touching to the wall and patient comes with great bite. Other things use mosquito net, cot, It will prevent scorpion sting, snake bite, dengue. Now the situation is very bad. आदमी में जहर इतना भर गया है कि विषधरों का सारा वंश डर गया है। एक दिन तुम जरूर सुनोगे कि आदमी के काटने से सांप कोई मर गया है। तो man is more dangerous than somebody was thinking about Iran, Israel and America. So there is a SV for snakes, but what is the antidote for man? Balla sir, kabhi Pune aaye to aap please visit this place. This is at Pimpri. This is a mule from our area, sir. Hingoli is near to Nanded. In 23 years, 4,520 liters of blood was taken. As we prepared well 35,000, lives saved were 3,500 at least. If a horse can do, animal can do this much for a man, then why man should not do for a man? This memorial is built by the government of Maharashtra. So, sir, we are working for initial days. I was searching house with toilet for 1 month. There was, my fight is not only with the snake bite. My fight is with poverty, load shedding. That time we were not having electricity for 20 hours. Poverty, misbeliefs, quacks. Here also in every village there is one Baba. First patient goes there and second. Even today also, after treating ventilator, patient goes to Baba. Under the, you just read that lines. This was my Oxford presentation. Sir, after this was Nepal. After earthquake, lot of snake bites in Nepal. They faced only 3. Whole government was there. But snake bite is neglected in India. Sir mentioned about this. Orissa, some doctor, sir is from Orissa. Sir, snake bites are more common in Orissa. President is from Orissa. I think she has taken recognition of my work because Orissa there is a bad scenario regarding snake bite. You better know than me. So the key to snake bite is awareness, B for basic life support, C for clinical assessment, counseling, corrective measures, compensation. Sir, I had a discussion with Honorable Finance Minister Nirmala Sitharaman. I requested her, Madam, please give a uniform and a good amount as a compensation to the poor farmer family, because if one farmer dies, one family dies. Then development, poison center, Rumta sir, this is activity, this center, this is a poison center, establishment of poison center, drug discovery, education, and first aid. For MBBS level, only things taught are venomous bite, non-venomous bite, ASV is indicated, patient goes to PSC, doctor is not knowing about the snake bite. If the doctor knows, ASV is not available. If ASV is available, doctor don't know how to give. If everything is available, people will not have a trust. He will bat the patient. Lot many patients, they die because of batting the patients. A poor victim of snake bite will not get the justice. So there is a man, our aim is catch a break and save the life. Simply on a mobile you can save the life. Man, money, material, method, machine, what lacking is only mind.
साथी हाथ बढ़ाना, साथी हाथ बढ़ाना.
Tell me, I will forget. Show me, I may remember, involve me, and I will understand. I can see the management there. If you give cooperation, 100% you will know that how to give cooperation. So snake bite is a universal responsibility. It is the responsibility of social workers. It is the responsibility of government. Responsibility of a doctor. Sir, out of 100, there was a day 95 MDs. They were not ready to touch the snake bite because they won't earn the money. They don't get the money. So every part of the society should be involved. And unless and until the situation of farmers is very bad, even though our country is, we can say, agriculture country, but in Maharashtra, a lot of farmers, they are committing suicide. So my appeal to all esteemed members is, sir, I don't know what kind of snakes are seen in Uttarakhand, whether mainly they are neurotoxic or respiratoxic, but now in our area, neurotoxicity has gone down. And this year, we have 6 villages were drawn, 95% were vipers. That has changed because of crop pattern, nature pattern. Uttarakhand might be having all big four. So this is the responsibility of all. So I deeply acknowledge all this. So I came across a long journey. I am really grateful to Dr. Runda sir for giving me this opportunity. But crane, cobra, Russell viper and soft scale viper, remember big four. To diagnose big four is not an easy task. Try to treat it. If you save one life of neurotoxin, you will have an immense of satisfaction. And if you one snake bite, you are going to save one farmer family. So this is my appeal to you all. Please come ahead and start treating snake bite. We answer our mission in each one. I educate at taluka, district, big conferences, national, international. So our aim is to reduce the mortality. So I hope I could tell you something. This is my experience as per the standard guidelines. So really, I am grateful to you all. And I am amongst all these regions. Uttarakhand will have definitely a benefit of this talk. If any needed, please, I will use the number. You can call me at any time. I am giving telemedicine advice to so many all over the country. So, really, sir, I am very grateful to you. I really stop here. Thank you. Thank you very much.
Well, ladies and gentlemen, I'm sure all of you are changed by his motivating presentation, talk. खुद ही को कर बुलंद इतना खुदा खुद तुमसे पूछे बता बंदे तेरी रजा की. He works in a small village. Probably Dharmawala is bigger than Mukhet. He was invited by the President of India. He is invited at Dharmawala, good 2000 kilometers away from where he works, because the fragrance of his work is spreading. I'm sure each one of us is motivated by what he is doing. I'll leave the desk for all of you to ask any questions if you want to ask him. But extremely thankful to you, Dr. Punde. Despite your physical handicaps, you have to have one caretaker with you while you are moving around. You have left your patients. The motivation is irrespective of what we have, what resources we have, what facilities we have. If we have a focus, we have a dedication, we can save patients. Everything else is a reason not to have achieved what we want. You may not have that lot of wealth, Dr. Kunde, but you are a wealthy man still. You have wealth of affection of lots of Indians.
आपके साथ हुआ भी है सर.
You have recognition by the government and you are loved by your own population. They are using as a god. They are happy to put your pictures on the walls with gods. Thank you very much. And I leave the dais with the opportunity if you want to ask any questions. And I will request Dr. Prashant, Professor of Critical Care Medicine at PGIMS Rohtak, to take the program forward. Now,
2013, I was taking 3 state bites. At 3 a.m., I had a massive AMI. My compounder took the ECG, massive interval MI. I was a patient, I was a doctor, I was thrombolized, and I was taken to higher center. Along with me, I took one cobra bite to that center. So I have such a lot of experience.
So our campaign is achieving zero mortality in poultry cases, what Dr. Punde has already achieved in cases of snake bite in this area. I will request Dr. Punde to join our campaign, help us out in cases of, we will get back to you whenever there is a, and join our data also, the campaign also, and enter your cases. We are allowing entering both prospective and retrospective. Thank you very much. Dr.
One thing I want to ask, after how much मतलब snake bite के कितने देर बाद तक snake venom हम ASV दे सकते हैं और there is any limit or
in a state of coagulopathy you can do ASV, but if patient has developed AKI, there is no role of, for that is a problem for a vasculotoxic bite. Generally ASV should be given in golden time only, but a patient comes late with all lab complication and still his PTIN is prolonged, US. Definitely ASV can be given. Sir.
Same question was asked to me once by my resident, because we ran out of it. We had the last 2 vials. There was a time when the regulation came in and the ASV production was halted. The question was asked in the reverse manner. You don't have ASV, what do you? You do not have ASV, just give it.
Neurotoxic can be cured without ASV.
Neurotoxic patients who require prolonged ventilation, they'll come out. Right? Vasculotoxic, if you support, we deal with Himalayan Bushfire.
There is no ASV.
There is no ASV there. So all you do is support the coagulation. You know, if there is bleeding, you support the graft, support the SVHM. So you will require more time for the patient.
Recovery will be slow.
Recovery is slow, but the patient will improve. So you do not have ASV, don't worry. You have ASV, give it. You don't have ventilator, give AMBU. We published our report. Nobody accepted. Clinical toxicology, which is the topmost level. They said, how is it possible? Why would you not give the patient ventilator? We treat around 200 patients every year within 3 months. In 3 months, if you have 200 patients of grade 5, I grade that nothing, so I grade with cobras, but I treat grade. Right? So you don't have ventilators, you run out of them, just give them ammo. And we had 2 deaths. One person died, the female died, because the husband fell asleep while he was ambling. He was the only person. He fell asleep and the patient
Went out.
Developed hypoxia. By the time we realized, she was still breathing, labored breathing, but she developed hypoxia. We put her on ventilator somehow, but we couldn't save her. And there was another patient who went to a Baba. by the time he came to us, he had a So these are, when our experience with PLA2 inhibitor, paper will come out and maybe a couple of days time. I have not seen such a dramatic response with PLA2 inhibitor, phospholipase inhibitor. Patient came completely paralyzed, would have required at least 48 hours of ventilation, was up and walking in well, out of ventilator, walking in well. I have not seen a response like that. Went to ICMR, told them that we should kind of expedite that. So that is something, if, as you said, it will be a game changer.
Definitely.
It will be a game changer provided it comes to India at a reasonable.
Soon, sir. So we will not be dependent on horses. Making ASV is a big job. They have to handle 1,000 horses. So if a chemical antidote, so that will be universal antidote, that will be the game changer. In future, you will have a tablet or injection of the chemical antidote. Definitely. We are waiting for that drugs. Actually, when it will come, I don't know.
The paper is coming out in 2 months. We just.
The molecular biology, lot of work is going on that level. Yes, madam.
So what is the choice of inotrope that you gave for patients with
NORAD. We are NORAD. We are using NORAD.
Even with the ones with capillary leakage, NORAD.
Capillary leakage is very bad.
That is a different ballgame altogether.
Right, sir.
Nothing will work there.
Right.
90% mortality. If patient goes in capillary, nothing, very, very bad. Because hypothesis is that some different antigen is there in venom which is causing capillary leak. That is common in Sri Lanka and Tamil Nadu. Worst problem of Russell Viper white is capillary leak. Thank you.
Thank you so much, sir. And as we started the introduction before you took this session for us was about the energy and enthusiasm, and I'm sure that your energy has given more enthusiasm to us than what we could have imagined. Thank you very much for being here. So let's move forward, and one thing to share with you all that for these 2 days we'll be talking less here and we'll be working more on simulated situations. So our full sim room is ready right at the corner of this hall only, and after we talk about the basics and some principles of various poisonings, we shall be working on the cases what we will be working on simulation. And my request to you all would be that कोई शर्म नहीं रखनी है, कोई संकोच नहीं रखना है, और जब हम एक सिनेरियो में काम करें तो हम ये सोच के काम करें कि हमारे पास this is the patient what you will be getting in emergency room or ICU or what.
Can you explain about
मैं अभी कर दूँगा. Rather than we go there, I'll have a full session to do that. So आप see that it breathes, it has pulses, it can even talk to you. So when we discuss the cases, it will not be like that we are giving you a history and out of that history and situation you need to pick up the points which you want to pick up and then treat. We'll have to pick up the points from the patient. If you want to know about the CVS, you will have to take the pulse, auscultate the heart, auscultate the chest. You want to know the volume, you need to take the BP. You want to know the respiration, you need to count the respiratory rate. But yes, what extra we will have, that you will have a monitoring facility, So if you do not want to count it by the watch, you apply the monitor and you will get the figures on the monitor as you get in ICU or emergency. Right? So my request would be again that do not hesitate and do not think that this is a machine, so this is not my patient. This is a near real patient what you have in this room. And that patient will have all the things you will come to see in a patient in this room life. Okay? So moving ahead with another important common topic, and as Dr. Mujay has said that snake को treat करने के लिए human था, हम हैं, हम उसे सोच रहे हैं. But now we come to something which is a man-made thing now, and it is a man-made problem now, and what we can do in it, we'll have to see. So what we have here is organophosphorus poisoning, and what burden we have is like this is again a poisoning which has a very high mortality, not only in India but all the countries from which the data is there. We take up a patient, 10 years male, comes to your emergency with history of accidental ingestion of some pesticide 3 hours back. While you receive the patient, he is undergoing CPR. After CPR, the patient is still comatose with a heart rate of 60 beats per minute, blood pressure of 90/60, and respiratory rate of 36. Pupils are pinpoint, non-reacting to light. There is frothy mouth with very noisy breathing, and SpO2 is 82% on high flow non-equilibrium mass at 12 liters per minute. What do you think is happening to your patient? क्या हो सकता है पेशेंट को? इंटरेक्टिव रहने की कोशिश करते हैं तो वहां पे भी इंटरेक्टिव होने में मजा आएगा. What can be there? क्या सोचना चाहेंगे? I am talking about OP, so this has to be OP at the minute. आसान था ये, फ्लू उसी के अंदर था, but अगर ये उधर से जवाब आता तो आप मजा आता. कोई, but हमने कैसे सस्पेक्ट किया? हमारे पास क्या ऐसे पॉइंट्स थे कि हमने सोचा कि ये OP होगा? Pupils, okay? You are worried about pupils here. Or secretions, wonderful. Secretions or ready, wonderful. So heart rate was affected or hypotension. Okay. So what's happening now? Again, we are going towards a point where we want to have a toxidromic approach. So even with the symptoms collected together, right, we can come to a conclusion that probably we are dealing with this specific poison. What sir has told us, if we can club the symptoms, what time patient has come from, what situation patient has come, and how he is presenting, probably it's easier for us to bring out the crate hoga ya cobra hoga ya what. So the same we can do it with the other poisoning also. So we go with the history of clinical presentation, and then to confirm the diagnosis we can think about acid and choline. This group which is dealing with this workshop has been part of guidelines in toxicology published by ISCCM 2 years back, and most of the things what I am talking is from these guidelines. So what are organophosphates? So they are organic esters of phosphoric or high phosphoric acids, generally used as sprays in the for pesticides. So what mostly you will get is someone coming from an area where there was a spray, either he was spraying or someone else was spraying, he was standing there. And it can be of two kinds. There can be organophosphorus or organocarbon. There are different names. So there are insecticides, there are nerve gases. So like sarin is common. If you remember from the history, it was used as a nerve gas. And then there are herbicides in it, and then there will be antihymics. But what happens here is that it is going to block the conduction, and that conduction is going to get blocked with the blocking of acetylcholinesterase. So how it is going to affect that? Once the conduction is blocked, so this will affect our conduction, and then this conduction, because of acetylcholinesterase, this will not pass through the split. So this was something you picked up from our patient, and these things were evident, and you started thinking about this may be an OP poisoning. And what is there in OP poisoning? There can be acute coronary syndrome, which will go either peripheral or central, and in peripheral, the effect can be musculoskeletal and necrotic. Generally, what is the easiest way to remember? Either the patient will be presenting with 3 Ps, that is bronchoria, bronchospasm, and tachycardia, or there can be some muscarinic signs which are here, and this is coupled with, to remember, we either remember it with sludge, BBB, or numbers. So there can be salivation, excessive salivation, lacrimation, urination, defecation, gastric emesis, bronchoria, bronchospasm, or if you remember with numbers, it would be defecation, urination, meiosis, bronchoria, bronchospasm, emesis, lacrimation. So we'll suspect with some history and clinical presentation, and for the confirmation we will take up. These things always make help in diagnosing, but to confirm, if you want to use cholinesterase levels, so there are 2 types of cholinesterase level: true cholinesterase levels, which are from the heart disease, or pseudocholinesterase levels, which are from the plasma, which can be used for diagnosis, but for monitoring and guiding the therapy, what we will require. What is going to kill our patient or put our patient in danger in OP poisoning is, first thing we need to remember is airway. So because of secretions, there can be airway blocked. So once the airway is blocked, the patient will die of airway problems. Then there can be bradycardia leading to cardiac arrest, and there would be respiratory failure because it can be either central or peripheral. The patient can also have aspiration pneumonitis or a delay in the diagnosis or leading to ARDS. Which patient to be admitted? All patients must be admitted for at least 24 hours or longer, even if they are totally asymptomatic. Because there can be an initial recovery, or there can be delayed onset, or there can symptoms be recovery. How are we going to manage? Always give priority to ABCD, what Dr. Bala sir has already taught, that we need to look for airway, breathing, circulation, and then come for detoxification or decontamination here. So ABCD, detoxification, use of specific drugs, and ventilating the patient as required. Now, OP might be coming from sprays, it might be coming from skin, it might have been absorbed to the clothes. So decontamination would be very important, but always remember to have your personal protective equipment while taking them. And when you need PPE, what you need is thick rubber gloves, because your simple gloves are not going to prevent crossing the OP. Right? So your protection is very important. So all clothing should be removed, changed, patient should be cleaned and washed. Our guidelines are against forced emesis, and activated charcoal can be used if the patient is received in the house, which is very unlikely to have a patient reaching hospital. Gastric lavage, we do not promote it with it. It should be done only after stabilizing a patient, never to be done with an unconscious patient under the airway is secured. At the same time, just for the sake of lavage, patient should not be injured. If done, use either water or normal saline, and it should be repeated if we are having a secure airway. Specific management, what will come is, specific management required would be either drugs, which can take care of the muscarinic part, so atropine or glycopyrrolate will come, or for cholinesterase activators, we can use pralidoxin. So what happens? Pralidoxin will deactivate the acetylcholinesterase, while atropine will antagonize excess acetylcholine at the postsynaptic level. So these two drugs will act at the. Atropine is the life-saving antidote for any suspected COVID poisoning. It is a competitive antagonist of acetylcholine, so it will block both central and peripheral effects. How to load it? Atropinization, give 1 to 2 milligram IV bolus, double the dose every 5 minutes. What we are looking, how do we know whether our patient has received enough or not? So there should be drying of secretion, there should be tachycardia. So by tachycardia, we do not mean a heart rate reaching 120, 150. If your heart rate comes above 180 and you are able to maintain it, it is good. Okay. Then dilatation of pupil, we should not be targeting for it because this might be achieved at a very high dose. What we need is drying of secretions and tachycardia, and for maintenance, what you can do is 10 to 20% of loading dose we can use. Yes, there are chances of atropine toxicity. We need to know it importantly, but need not to be scared of it. Patient may have confusion, hyperthermia, paralytic areas, or urinary retention. A differential diagnosis of alcohol withdrawal or paralytic areas should be there. Alternatively, you can use glycopyrrolate. It has an advantage that it does not cross CNS, but it's always better to initially use atropine. It may be used when we have control of copious secretions or features of atropine toxicity. A little controversial drug, pralidoxin, considered to be specific antidote, but its role remains controversial. Binds to OP compound and deactivates the phosphorylated acetylcholinesterase. Literature reviews suggest a mixed response. So there is response that there is insufficient evidence to support it, but then a landmark paper from Dr. K.P. Gavarata published in Lancet 2006, where double the dose of pralidoxin was, as recommended by WHO, was used, had a significant improvement of mortality, but the group present here who prepared the guideline also does not support routine use of pralidoxin for all. WHO dose is recommended about 30 mg per kg loading over a period of 10 to 20 minutes, followed by continuous infusion and a rate of 8 to 10 mg per kg per hour to be continued. The good thing to remember about PAM is if you want to use it, you have an indication, you receive a patient early, hit hard, and keep on. So if we are able to give it early, then only we will be able to prevent the enzyme from aging when it becomes irreversible. So if you use it, you need to use it early, and when you need to use early, you need to use full dose of the drug. Using a lower dose is not going to happen. Another paper from India, from the speaker. Again, they have shown that there may be a variable response. There will be a variable response. So we need to think about that also. Overall, PAP is not recommended for all patients to use, but what is going to save our patient is do not forget to ectopenize the patient. Do not be scared of ectopenizing the patient. Targets, we know what targets we need to look for. From there we need to stay. Then what else our patient can have? Our patient can also have intermediate syndrome. So there can be sudden development of weakness after 3 to 4 days from exposure or after resolution of acute crisis. There can be facial, neck or proximal muscle weakness. There can be respiratory muscle weakness coming again. It can be self-limiting. No specific treatment is required, but we need to maintain the patient. Mechanical ventilation would be required for all those patients with severe poisoning who are having massive secretion or pulmonary edema and unable to maintain their airway. While intubating, the message here is to avoid succinylcholine. If we need to use propionine, would be a good choice. And non-invasive intubation is not going to have this issue because we need to secure the airway. In case our patient requires sedation or has seizures, benzodiazepines would be the drug of choice. Other safe drugs might come as a protocol of activity and so what specifically the patient which we are talking about received? If you still remember our patient, young boy, history of accidental ingestion. He was enteropenized. He was also given fan, intubated, mechanical ventilation, on entropene infusion, and patient recovered. And patient recovered from GCSO3 after CPR, which was going on when you received the patient in emergency, to complete recovery. So what is the key to survival here? Early recognition. If indicated, LAVAR, you are receiving patient early intubation and ventilation, bolus of atropine and infusion, selection criteria for entropenization, dryness of airway and control of tachycardia. Remember, no dose of atropine is too high. Also look for prevention of infection, standard ventilation, be prepared for intermediate syndrome, treat in a closed unit. Therefore, the message should be that no opioid poisoning patient should die in the current era of mechanical ventilation once introduced. And I'm sure in these workshops, with your enthusiastic participation, this will change. Thank you very much. I'm happy to answer any questions, or we will take up the questions when we go to the hands-on working with the simulator. Can we have a tea break or we continue with the okay. So
what is your experience regarding
that came in 2006. This group doesn't use sir.
I don't use Tupam at all. I don't use Tupam at all. There are 3 reasons for it. Because an average time interval for a patient to come to us in a tertiary care center is more than 5 hours. So, and you have patients who have early aging because of irreversible finding. That doesn't work. From our experience, Dr. J.V. Peter's experience, PAM does not. You're talking about Kirti Pawars paper. Kirti Pawars patient came to her in the hospital early in the course, and they gave them a very high dose, around 50 grams of 2-PAM over 48 hours. 2 grams stat, 1 gram every hour for next 2 days, 48 hours. Very expensive treatment with very few results. The same result you can achieve by using atropine and mechanical ventilation. The paper by Michael Edelston, I worked with him, very good friend. And the paper from Sri Lanka has shown that in spite of acetylcholinesterase reactivation, documented, does not make a material difference in the final outcome, either in the duration of ventilation or the survival. So the key for 2-PAM use is how early you can do it. So if it is used in first 1 to 2 hours, can be used. But the recent BMC clinical practice guidelines, which again is written by Nick Buckley and Michael Edelston, they have written that 2-PAM should be used only in research settings, where you want to prove what dose you want to have, or you want to use it further. I don't use it, I haven't used it in last 20 years. I haven't used a single dose of 2-PAM. We stopped buying 2-PAM in people. And the same thing is true with Dr. J.V. Peters' group. What he has done, Dr. J.V. Peters is also one of them. Dr. J.V. Peters has shown in lab that even if you show reactivation in the lab by using 2-PAM, still the mortality, the duration of ventilation, the complication do not change. So I am a non-believer in 2-PAM. Okay.
Sir, I would like to say that we have not used PAM in the last 20 years. When I say, he says, or anybody says about a controversial thing, that doesn't mean that you should not use PAM at all. This is, when there is a controversy, you may have a choice. But you should keep your mind open, keep your eyes open, and trying out a combination of PAM and atropine. Atropine remains the principal antidote to OP. So there is no way you can avoid atropine. Atropine, and no dose of atropine is too high. We have used up to 33,000 ampules of atropine in one single case over a period of about 7-8 days. And I have never seen toxicity of atropine. Others must have seen. Therefore, it is mentioned in literature. So you must do some cases without PAM and few cases PAM with atropine if you want to use PAM. We last 20 cases that we have dealt with, we have not used PAM. Survival has been 100%, and it is the survival in PAM, OP poisoning, and hearing about 100% survival in snake bite cases and improved survival in current methods of treating aluminum phosphide poisoning. Earlier we understood that ALP poisoning means death. Now we report almost survival up to 75% by various methods. I am not talking about what is good, what is bad, but there are reports of 75%, 80% survivals. True. So, if we don't try out at various places in different ways, ultimately, we should learn. We should keep our minds open, and then you can settle down. I have settled down with only atropine. Dr. Bhalla has settled down with only a little bit. Dr. Peter has settled down. We are all colleagues. We sit together and discuss. But Kirti, when she was ready to fight it. And I remember her dialogue. ये अन्याय कब खत्म होगा? आप लोग मरीजों को कब तक मारते रहोगे? So these dialogues are avoidable, but we have kept our minds open, and I advise all my colleagues to keep their minds open. You can use it is available training, it is costly, but you
Look at
should
the evidence.
look at the evidence.
There is a recent systematic meta analysis which has looked at all the evidence and suggested clearly family.
I just wanted to comment. I have not used palm after 1988, and I have not had one death in organ transplant. Number one. There was in case report, and there were case reports after that. That if you use palm, the incidence of intermediate syndrome perhaps is high. Intermediate syndrome, if it is high and it hasn't produced any mortality benefit, without palm we have had 100% survival. Why use palm? 38 years almost I have not used palm.
I could not resist echoing the same thing.
Yes.
Like last 15-20 years, we've also not used palm, and the complications are similar.
Yes.
So I've been successful in convincing people to don't use it. So I've convinced a couple of them it's of no use.
So Dr. Pujil, you should visit Madam. She is not far away from your place. I had to run away.
So, tea is ready, and with the tea break, we will continue to one hands-on simulation scenario. Before we go for the tea, we'll not have a scenario in terms that everyone would be working with the patient at one single time. We'll be working in a team, right? So I want 5 volunteers for first patient. So who's going to be lead for the first case management as 5 volunteers? I want 5 volunteers. ऐसे तो बोर हो जाएंगे सब, हम भी बोर हो जाएंगे, आप भी बोर हो जाएंगे, क्या फायदा? सर, थैंक यू सो मच। सर 4 आप सिलेक्ट कर दो अपने साथ। अगर नहीं आते तो you are the lead, you take 4.
Yeah, good. This line, sir.
This line?
You want it.
Okay, चलो। So जल्दी से चाय लेते हैं and then we will. Yeah.